about anesthesia machines and physics in anesthesia. So over to you, Prasad, sir. Sir is going to talk about renal physiology.
Thank you, Rosna.
Share the screen. You can share the screen now.
Yeah, 1 minute, sir. At the outset, I would like to thank Dr. Bala Bhaskar sir, Dr. Srinivasulu sir for giving me an opportunity to be a part of this event. Today, I'll be talking about renal physiology and renal function test. Because of the time constraint, I have condensed very briefly. I'll be telling briefly. Any doubts in later, anybody can ask me questions later, please. So coming to renal physiology, renal function test. Renal physiology encompasses all the functions of the kidneys. The most important functions are elimination of metabolic waste products, regulation of water and electrolyte balance, acid-base balance, regulation of blood pressure, and production of hormones. So, and most of the renal physiology is studied at the level of the nephron. And coming to physiology, the functions, the physiology can be classified as regulation, production, and waste excretion. So it is involved in the regulation of fluid balance, electrolyte balance, and the production of vitamin D 125 dihydroxycholesterol, renin, erythropoietin, and it's also involved in exogenous, endogenous excretion of waste products. So before going to physiology, briefly about anatomy. As you all know, kidney extends from T12 to L1 vertebra. It's around 12 centimeters, and it has got mainly the outer cortex and inner medulla. The medullary pyramids, the apex of the medullary pyramid opens into calyces, and the functional unit is a nephron. The nephron consists of the glomerulus, and which leads on to proximal convoluted tubule, the loop of Fenley, distal convoluted tubule, and the collecting duct. And the very important point regarding the nephron is this: there are two types of nephrons. One is cortical nephron, and the other one is the juxtamedullary nephrons, which is situated at the junction of the cortex and the medulla. And 85% of cortical nephrons, and only 15% is the juxtamedullary nephrons. Juxtamedullary nephrons has got the juxtaglomerular apparatus, which consists of the macula densa, the cells arising from the ascending loop of Fenley, and the granular cells, which is arising from the afferent arterioles. This secretes the macula densa responds to composition of tubular fluids, whereas the granular cells helps in secretion of renin. Now, before going to physiology, an introduction about the renal blood flow. The kidneys receive blood from the renal arteries. About 20 to 25% of the cardiac output, it receives around 20 to 25% of cardiac output. It is approximately 1000 ml per minute. It is around 300 to 400 ml per 100 grams, out of which the renal cortex receives 90%. This is called as luxury perfusion. This is mainly to maintain the GFR. The remaining 10% is for the medulla. Coming to the actual supply of blood supply, the renal arteries enters the kidney at the hilum, and it divides into the interlobar arteries. At the junction of the cortex and medulla, it arches, and from the arcuate arteries, these arcuate arteries give rise to the interlobular arteries, which in later this give rise branch to afferent arterioles. These afferent arterioles supplies the glomerulus, which form the glomerular capillaries. These capillaries later forms the afferent arteriole. This afferent arteriole again leads to peritubular capillaries, and this peritubular capillaries forms the interlobular vein and the arcuate vein, interlobar veins, and the renal veins. And the kidney has got autoregulation, where the blood flow is maintained between the mean arterial pressure of 60 to 160. The flow is maintained. The various mechanisms involved are the myogenic mechanism, the tubuloglomerular feedback, sympathetic nervous system, renin-angiotensin aldosterone system, renal prostaglandins, and atrial natriuretic peptide. Coming to the actual physiology, kidney excretes the metabolic waste products by forming urine. This takes place by 3 steps: glomerular filtration, tubular reabsorption, and tubular secretion. The blood enters the glomerulus through the afferent arterioles. In the glomerular capillaries, it is filtered and it passes to the proximal convoluted tubule, where the reabsorption of about 70% of water, sodium, chloride, 100% glucose, amino acids are reabsorbed, and later it enters the loop of Henle. When it reaches, the main function of the loop of Henle is to form a hyperosmotic medullary interstitium, so that it helps in reabsorption of electrolytes and other important things which is necessary. So this mechanism is called as countercurrent medullary system, and the similar mechanism from the medullary interstitium, where it is absorbed to the blood vessels, it is called as countercurrent exchange system. If later will be discussed, if anybody has got, we'll discuss this later. Then from the loop of Henle, the descending loop of Henle is highly permeable to water. So by the time it reaches the tip of the loop of Henle, it is getting the urine get concentrated, and when it ascends, when in the ascending loop of Henle, it gets diluted. So when it reaches the DCT, the urine is hypotonic. In the DCT, depending upon the secretion of ADH, the concentration of urine takes place, and in the collecting tubule, it passes and a concentrated urine is formed. This is in brief about the formation of urine. Coming to GFR, glomerular filtration rate, the filtrate depends upon the area and permeability of the membrane. It depends upon the oncotic and hydrostatic pressure of plasma, and it also depends upon the molecular size and electrical charge of the particles. The volume of filtrate is 125 ml per minute or 180 liters per day. The filtration fraction is nothing but the fraction of plasma that is filtered. As we know, about 20 to 25% of the kidney, the cardiac output, the kidney receives. So the plasma constitutes about 55 to 60% of that. It is around renal plasma flow is around 600 ml. So when we divide renal plasma flow by GFR 125, the filtration fraction is around 20%. That is, the total out of the total plasma, 20% of the plasma is filtered. Coming to the main functions of kidney tubules, the proximal convoluted tubule, that is a reabsorption of sodium, chloride, bicarbonate, glucose, amino acids, and water is obligatorily absorbed. Secretes hydrogen ions, acid and bases, and ammonia. The loop of Henle, where the mechanism that I told in the beginning, it's about the countercurrent medullary system. Sodium, chloride, calcium, and magnesium ions are absorbed, and urea is secreted. In the distal convoluted tubule, depending upon the presence of ADH hormone, the sodium, chloride, and water is absorbed. Hydrogen, potassium, ammonia, and uric acid is secreted. Here I put the effect of the diuretics at the different levels. The osmotic diuretics acts at PCT. It decreases the reabsorption of solutes. There is obligatory water. There will be obligatory water excretion. Carbonic anhydrase decreases the dissociation of carbonic acid. This results in decreased reabsorption of bicarbonate, sodium, and water. Thiazides decrease sodium reabsorption in DCT. So there is water excretion. Furosemide decreased chloride reabsorption in the loop of Henle along with sodium and water. Potassium, it leads to potassium depletion. Aldosterone antagonists like spironolactone decreases sodium reabsorption as DCT. There is obligatory water excretion. So the other functions are, kidney also helps in control of acid-base balance. The kidney regulates the extracellular hydrogen concentration by three mechanisms, basically secretion of the hydrogen ion, reabsorption of filtered bicarbonate, and production of new bicarbonates. Here you can see here the hydrogen ion is secreted, and intake the sodium enters the cells, and this hydrogen ion combines with bicarbonate in the tubule to form carbonic acid, and which dissociate into carbon dioxide and water. Again, carbon dioxide enters into the cells. At the same time, when the bicarbonate which is inside the cell, when it goes into renal interstitium, chloride enters the cell, and later this is secreted. At the same time, the hydrogen ion secreted into the tubules also combines with sodium hydrogen phosphate to form sodium dihydrogen phosphate. So titratable acids are formed in the renal tubule. Another mechanism is this hydrogen ion which is secreted also combines with ammonia to form ammonium, and with this ammonia combines with chloride, with the chloride ion to form ammonium chloride, which is excreted. Now coming to control of blood pressure and fluid balance, regulation of fluid balance. Whenever there is a decrease in the extracellular fluid volume, there is activation of sympathetic nervous system, which results in vasoconstriction of the afferent arteriole. This results in decrease in GFR. This results in activation of renin-angiotensin-aldosterone axis, reabsorption of sodium chloride and water at the DCT, and this increases GFR and BP, and extracellular volume is restored. This is how the renin-angiotensin system works. The renin, which is secreted in the kidney, converts angiotensinogen to angiotensinogen 1. This angiotensinogen 1 is converted into angiotensinogen 2 by the angiotensin converting enzyme. This angiotensinogen helps in release of aldosterone from the adrenal gland, which in turn results in absorption of sodium chloride and water in the DCT, and blood pressure is maintained. Now, coming to the second part of my talk, renal function test. Renal function test, what test we advise for the patient depends upon the condition of the patient. So we have classified renal function test as to screen for kidney disease and to assess renal functions. For screening, commonly we do complete urine analysis, plasma urea and creatinine and plasma electrolytes. To assess renal function per se, we do glomerular function test. In this, we have two types: glomerular filtration rate by doing clearance test. The other one is the permeability test that we assess by doing assessing proteins in the urine. Tubular functions, we have reabsorption studies, concentration and dilution test, and renal acidification tests. Coming to the urine analysis, the normal volume of urine per day excreted is around 1 to 1.5 liters. And when it is less than 300 ml, it is called oliguria. And when it is more than 3000 ml, it is called as polydipsia. So depending upon the appearance, normal urine is straw-colored, and if it's high-colored, it's concentrated urine. Sometimes oxidation of urobilinogen to urobilin. If it's yellow color, we think of bilirubinuria. Smoky red indicates the presence of blood. Brownish red indicates hemoglobinuria. So this gives a fair idea about the condition of the patient appearance. Now coming to the abnormality detected on dipstick test, we commonly tests that are done are the specific gravity test. The normal specific gravity is 1.005 to 1.025, and pH is 5.5 to 6.5. Proteins, usually proteins are not excreted, even if it's present, is less than 150 milligram per day. And the test that is done is heat or acetic acid test. Glucose is done Benedict's test. Ketone bodies or Rothera's test we use, and bile salts by Hayes test. Coming to the common test to assess kidney functions, as I told in the beginning, we do serum creatinine, urea, uric acid, and electrolytes. So these are the normal values and factors affecting the various constraints. Coming to assess the renal function, we do glomerular function test. In this, we do clearance test and permeability test. Coming to the clearance test, creatinine clearance is used to assess GFR. We can also use inulin, but inulin is exogenous. We have to infuse inulin to the patient, so it's not used. And the other method, which is uses cystatin C, I'll be talking about that later. Coming to creatinine clearance, creatinine endogenous marker for renal filtration. Serum creatinine does not increase until GFR has moderately decreased, about 40 to 70 ml per minute per body surface area. This area is called as creatinine blind GFR area. So serum creatinine is not very clear until GFR is moderately decreased. So creatinine clearance is used to measure GFR. Creatinine coefficient is nothing but the urinary creatinine in milligram per kgs. The GFR is calculated by three methods. One is creatinine clearance. Creatinine clearance is equal to urine creatinine into volume of urine divided by serum creatinine into time. This is one of the commonly used methods. The other method is the Cox-Galt equation. And the other one is modification of diet in renal disease. It is MDRD equation. Normally, the serum creatinine is estimated, and later by using the modification of diet in renal disease, we calculate GFR. Cystatin C. Cystatin C is a protein produced by all nucleated cells, and it is filtered and it is not reabsorbed by the kidneys. It is a marker which has an advantage over serum creatinine. Cystatin C based measurements of GFR is more accurate than creatinine based. Normal levels of cystatin is around 0.8 to 1.2 milligram per liter. Coming to when to measure the glomerular permeability, we do proteinuria. Usually proteins are not excreted in the urine. Microalbuminuria, that is 30 to 300 milligram per day, is the earliest sign of diabetic nephropathy. Persistent proteinuria suggests significant renal disease. When the proteinuria is around 300 milligram per day, we think of benign proteinuria like pregnancy or renal process. When it is 300 milligram to 1000 milligrams, it is called pathological proteinuria. When it is more than 1000 milligram per day, it is glomerular proteinuria. Since estimation of proteins in the urine for 24 hours is difficult and it's a cumbersome procedures, they use what is called as urine albumin to creatinine ratio. Urine albumin to creatinine ratio is used to detect proteinuria. The normal value is less than 23 milligram per gram in females, and it is 27 milligram per gram in males. If it is more than, it is around 30 milligram per gram, it is called as mildly increased. We can also express this as 3 milligrams per millimoles. When it is around 330 to 299 milligram per gram, it is moderately increased. We can also express it as 3 to 29 milligram per millimoles. When it is more than 300 milligram per gram, it is severely increased. So this gives a fair idea about the proteinuria that is going on, taking place in the body. Next, the assessment of renal tubular functions and integrity. Renal tubular functions is assessed by measuring urine concentration ability, that is mainly the specific gravity. Tubular functions is observed by reabsorption studies, concentration and dilution tests, and renal acidification. The novel biomarker for tubular injury is urinary neutrophil gelatinase associated lipocalcin. Early detection of acute kidney injury before a change in GFR. The urinary neutrophil gelatinase associated lipocalcin is useful when serum creatinine levels is not increased. If test for tubular functions or concentration test, here we do specific gravity. Specific gravity is measured after 12 hours of fasting. When the specific gravity is more than 1.022, it is normal, can go up to 1.032. When it is less than 1.022, we think of tubular dysfunction. Coming to dilution test, water load of 1200 ml is given in 30 minutes. Hourly urine samples for 4 hours we collect and we calculate the specific gravity. When the specific gravity of at least one sample should be less than 1.003. When it is more than 1.003, we think of tubular dysfunction. Next, the other test is urinary acidification. Indication is unexplained hyperchloremic metabolic acidosis. Ammonium chloride 0.1 gram per kg body weight is given, and urine is collected 2 to 8 hours after ingestion. pH of at least one sample should be less than 5.3. When the pH is more than 5.3, we think of renal tubular acidosis. The other test that is done is fractional excretion of sodium. The fractional excretion of sodium is nothing but percentage of filtered sodium that is excreted. That is filtered sodium by GFR gives the what is fractional excretion of sodium. Normally it is less than 1%, but this fractional excretion of sodium helps to differentiate between pre-renal and renal causes of azotemia. When it is more than 2%, that is urinary sodium concentration is more than 40 milliequivalent per liter, it indicates tubular dysfunction. When it's less than 1% or urinary sodium excretion less than 20 milliequivalent per liter, it suggests pre-renal causes. Now, this is how the formula used to calculate the fractional excretion of sodium. Here, urine and plasma concentration of creatinine and sodium are measured in milligrams per deciliter. So, in summarize, the renal functions test, these are commonly done and how the variation takes place. This by doing serum, what has been boldly written here, commonly done, indolent or rarely done. So serum urea, serum creatinine, creatinine clearance, proteinuria, volume, urine volume, subsidiarity helps us. By doing all these tests, we get a fair idea about whether the numeral is affected or it is the tubules that is affected. So now, after knowing all the physiology and the renal function test, what are the anesthetic implications? Whenever there is a kidney disease, it alters the pharmacodynamics and kinetics of drugs. This may result in toxicity. Therefore, careful selection and dosing is very, very important. In this, we should be very careful because the patient will be on other drugs like diuretic. So previously, I've told about what are the effects of diuretics here. I'm coming to the anesthetic drugs. Regarding the inhalation agent like methoxyfluorine and enfluorine contains fluorine, nephrotoxicity. Other agents can commonly be used, but the effect of the inhalation agent on the renal, we should keep an idea because it may reduce the renal blood flow. We have to titrate the dose. And during muscle relaxant, as you all know, we commonly use the atracurium or cisatracurium. Other muscle relaxants has to be avoided. And regarding the intravenous agents, carpentone, there is a free fraction because of less protein binding. So dose has to be reduced. So we have to be very careful while selecting the dose of the drugs. Next, the other problem is fluid overload. In patients with the kidney disease are prone for fluid overload. It may lead to pulmonary edema. It may cause dilutional hyponatremia. It may lead to congestive cardiac failure. So conservative fluid management is very important. And the other problem is electrolyte imbalance, because the electrolytes imbalance are very common in kidney disease. There may be hyperkalemia, hyponatremia, or hypernatremia, depending upon the condition of the patient. It may lead to cardiovascular, neuromuscular function may be affected. So monitoring of electrolytes is very important. And along with kidney disease, usually they have comorbidities like the hypertension, diabetes, ischemic heart disease. Due consideration for the problems and potential risk associated should be considered before taking up the patient for surgery. Another important point is doing positioning also. It becomes very important because when you put a patient in lithotomy position, it may compress the renal vein and decrease the renal blood flow. So all this has to be considered while taking the patient for anesthesia. These are my references. Thank you.
Thank you, Dr. Prasad. I think we will take all the questions at the end. Session is over. Dr. Jyotsna?
Yes, sir. So we shall introduce our next speaker, Dr. Sudarshan Lakhe. Sir is going to talk about acute renal failure. Sir is working as a consultant, chief consultant in United Hospital at Gulbarga. And sir has done his MD anesthesia from AIIMS, New Delhi. He has worked in various other hospitals as consultant anesthetist and critical care intensivist in Chirayu Hospital and also in Kuwait. Sir, over to you, sir.
Thank you, Dr. Jyotsna. Hello, I'm audible, sir?
Yes.
Yeah.
Okay.
So you're audible, sir.
Thank you for the opportunity. I'll go ahead with quickly go ahead with the perioperative acute kidney injury, how we can see through the, okay. I'll be going through the few headings, like the definition, the risk factors involved, and the common causes for the postoperative AKI, how we can prevent AKI, and pharmacological methods for management of the AKI, and lastly, renal replacement therapy in case of AKI. Why we need AKI? Why is so important to us? Because in the last 1 decade, the admission of the elderly population has doubled now. And the incidence of the AKI in developing countries on 5%, and in developed countries nearly 20% now. When it comes to ICU, the admission with the AKI is almost account to the half of the population. What AKI contributes is the increase in the morbidity and mortality, larger hospital stay, and financial burden, as well as the leading to CKD. There are numerous studies where they documented effects of incidence of AKI. The Koch et al. In 2015 demonstrated nearly 6%, and even minor changes in the creatinine level, the increase of death by 2-fold. The same way in 2017 Connor and 2016, Hu Chen et al., they demonstrated the incidence. In 2016, the Hu Chen demonstrated in cardiac surgery, the incidence is nearly 25%. And requirement of the renal replacement therapy was like nearly 2.3% of the patients. Looking at the definitions, AKI is grossly defined as the acute deterioration of the kidney function as reflected by the significant increase in the serum creatinine levels. In most of the patients, nearly 70% of the patient, the urine output has already decreased. So acute dialysis quality initiative group came up with the idea of having a criteria for the definition. They introduced in 2014 a RAFEL criteria, which includes the R for risk, I for injury, F for failure. These three stages they included, and end-stage functions like loss of kidney function and stage regional kidney disease, they include as like outcome of the injury. Because of some limitation of the RAFEL criteria, which doesn't include the early kidney dysfunction, they formulated after 3 years like Akin criteria by the Acute Kidney Network. The same group in 2012, they formed the other group, other definition where they included both RAFEL and Akin criteria, and they've come up with the idea of acute kidney disease improving global outcomes. The KDIGO is a criteria is recently followed, and most of the people now accept these definitions. What KDIGO definition has done to us, basically, it has unified the terminology so that it can include it in every research and compare them among the studies. It can raise the awareness among the general practitioners and enable earlier detection and possibly the prevention, and so improve the outcome. The definition itself is basically a time factor involved here. They refer to the time of AKI development, and it's based on the serum creatinine level, increase in serum creatinine level, and the urine output, drop in urine output. There are three factors here: the increase in serum creatinine level at least by 0.3 milligram per deciliter within 48 hours, or 1.5-fold increase in the baseline occurred within the 7 days, preceding 7 days, or urine volume below 0.5 ml per kg per hour, at least in last 6 hours. Depending on these three values, they have stated in 3 stages. They have made it 3 stages. Basically, the first stage where the creat is elevated more than 0.3 milligram per deciliter, or 1.5 to 1.94 higher than the baseline. When it comes to urine output criteria, they include in stage 1, 0.5 ml per kg per hour, nearly for 6 to 12 hours. In second stage, the creat level from 2 to 2.5-fold higher than the baseline, or urine output less than 0.5 ml per kg per hour, more than 12 hours. In stage 3, what they have done, the increase in the creat is increased more than 4 milligram per deciliter, or initiation of renal replacement therapy, or could be 3-fold higher than the baseline. When it comes to urine output criteria, they include 0.3 ml per kg more than 24 hours, or anuric for nearly 12 hours. These are 3 stages where the KDIGO definition they included. There are even though we have gone through the KDIGO definition, it itself has some limitations. The largest controversy was the increase in serum creatinine more than 0.3 milligram per deciliter. It could be a lab error also. It could be a physiological fluctuation also. When you have a decrease intake, there could be minor changes in the creat level. And moreover, patients with the CKD, there are minor changes in the creatinine level happens day to day. And more second point was the baseline creat level. But the true baseline for the most patients, we don't know it. And third point is the diuresis criteria. Diuresis criteria varies to patients. When you use diuretics and fluid therapy, excessive fluid therapy, diuresis happens significantly despite the kidney injury. Like major surgery, the oliguria is basic, most of the time is a physiologic process. The release of the aldosterone and the vasopressin from the stress. And the third point was drop in urine output, 0.5 ml per kg per hour for 6 hours seems to inadequate, inadequate when it comes to defining. When the patient have lesser fluid intake, the 0.5 ml per kg per hour within 6 hours could be adequate also. And the KidCo doesn't differentiate the functional AKI, where the prerenal allosteromia or the hypovolemia lead to the functional AKI, and the structural tubular injury doesn't differentiate between these two. So the serum creatinine is actually the kind of imperfect biomarker what we consider, and there is a still hunt on for the better marker for like NGAL or kidney injury molecule 1 and cystatin C. Why creatinine is imperfect? Why we call it imperfect? Because creatinine is a functional marker and concentration doesn't rise late in AKI. It almost like when kidney functions drops by 50 to 60%, then creatinine will start raising. So there is something called a creatinine blind window of acute kidney injury, where the rising creatinine occurs in day 1, but the most of to fail to meet the criteria of AKI until day 2. This is called the creatinine blind window of the acute kidney injury. If you see through the a small slide, one slide for the where how the creatinine in purple line is the creatinine and the NGAL is a red line. So basically NGAL gives us a better picture of the acute kidney injury rather than the creatinine, which will take nearly 24 hours to rise. Just for the reference. What are the risk factors for the perioperative AKI? Perioperative risk factors are the kind of very complex and is multifaceted. The most common cause is the hypoperfusion, inflammation, and neuroendocrine response to surgery. The inflammation induced in AKI is also, in fact, is multifactorial. It could be like oxidative stress, cytokine-induced injury, tubular injury, endothelial injury, and the activation of the pro-apoptotic pathways. The changing, there is rather than putting risk factors, now there is changing, what we consider the changing spectrum of the AKI in hospitalized patients. Because the isolated injury of the kidney is rarely happens, it's very rare, but most of the times it includes part of the multi-organ dysfunction syndrome. Isolated acute kidney injury usually most of the times is contrast media, drugs, other nephrotoxin, and mostly rhabdomyolysis. But the most common is the multi-organ dysfunction syndrome, where the sepsis, cardiac surgery, multiple trauma injury, severe burns, and extra-abdominal surgery, acute hepatic failure contribute to more. If you want to roughly define the perioperative risk factors, we have to consider the patient-associated risk factors, the surgical-associated risk factor. The surgical-associated risk factor is basically site of a surgery-associated risk factor, and intraoperative and post-operative factor. We can divide in these 3 groups. Patient-associated risk factors, basically the pre-existing renal disease at most important one. Elderly population, African American race is one of the predisposed to AKI. Hypertension, diabetes, heart failure, pulmonary disease, high body mass index, and hepatic diseases, and of course sepsis. These are the patient-related risk factors. When it comes to surgery-associated risk factor, the surgical-associated risk factor can divide into 2 groups, cardiac and the non-cardiac surgeries. Why we have to divide is because the acute kidney injury related to cardiac surgery is studied extensively. That's the reason it's better to mention the cardiac and non-cardiac in separate headings. In cardiac and vascular surgery, the incidence of the AKI is around 20 to 30% due to its prolonged aortic cross-column, formation of the micro and macro emboli, low mean arterial pressure, and low cardiac output related to CPB. There is also contribution of the artificial surface contact, which lead to activation of the systemic inflammation. These all basically lead to the renin-angiotensin aldosterone activation, declining in the regional perfusion pressure, and leading to the acute kidney injury. There is a off-pump, on-pump study where going on. One study where said the off-pump has a better outcome compared to the on-pump. But overall, current evidence doesn't support any of the differences between them. In non-cardiac surgeries, which is basically studied very less extensively, the overall incidence varies. Up to 6% is there, and the 30th day mortality might increase to nearly 8%, eightfold. Grams et al. He has studied nearly 160,000 patients, where he has formulated the high-risk surgical procedures, where he said the general thoracic and abdominal surgery have the highest incidence of the
CCU. Any neuro patient should be seen when neuro unit as a primary.
Please mute yourselves. Anybody? Sorry.
Yes, so because yeah, basically general thoracic surgery has the highest incidence along with the abdominal surgeries, followed by the orthopedic, vascular, and urologic, and the ENT surgeries are the least one. Intraoperative and the postoperative factors. The intraoperative and postoperative factor, those most of the times both are combined. What we exactly mean by the intraoperative, postoperative related factors is basically the hemodynamic stability, how we manage. So intraoperative, basically, there is an intraoperative blood transfusion or episodes of hemodynamic instability, use of the vasopressors and diuretics, and increase in the abdominal pressure, which is basically more important, most neglected in the post-op period, and fluid overload or major fluid shift is the main causes. If you want to check down the exact causes of the intraoperative period, for the exam point of view, you can write it down like hypovolemia, kidney ischemia, inflammation, increased abdominal pressure, decreased cardiac output, vasodilatation could be related to the drugs, exposure to necrotoxins, multipharmacy may be the reason, and embolism. These are the core possible causes for the intraoperative. And the postoperative is basically same as the intraoperative, but add on these things are urinary tract obstruction is one of the cause. Acute lung injury might be because of the multiple transfusion or other related. Mechanical ventilation itself can be leading cause. Common cause of the postoperative AKI. Common cause of postoperative AKI basically almost same things like what we consider intraoperative factors. But if you check down common causes for the postoperative, we can consider hypovolemia is the most important thing, and kidney ischemia the second. Increased abdominal pressure is the third one, and the NSAIDs and nephrotoxic medication, and in fact the sepsis following infection is the most. These are the most common cause. Prevention of AKI. For the prevention of AKI, we should have an idea of the pathophysiological classification of the renal injuries, like pre-renal injuries and the post-renal injury and the regional injury. If we have this idea, what exactly they're causing, then we can have better manage in the preventing the AKI. Prevention of AKI, basically, we can look into the three broader heading: identify the risk factors, modify any other any factors involving the kidney injuries, and goals for the intraoperative, how we can manage intraoperatively. So identifying the patient risk factors of AKI is basically consider the baseline characters of the patients, whether it's a diabetic or hypertension, or whether he has any other coexisting morbidities. Baseline creatinine is most important. See whether baseline creatinine is actually on the higher side, or it could be a pre-renal ischemia. Type of surgery involved. In case of the cardiac surgery, definitely the risk will be higher side, so manage accordingly. Abdominal surgery, keep a watch, avoid polypharmacy, and other comorbidities. Fluid shifts also one of the major causes. These are the basically most risk identifying the things. Several models or guidelines have been tried, but none have been used because of many limitations. Maybe the novel biomarkers, maybe NGAL kind of thing, where the early detection and the point of care detection comes, maybe they'll help in the formulating the guidelines in future. Modification is the next thing, basically identify the underlying causes, and if possible, treat them. Removal of any potential insults that minimize the additional injuries. There are additional measures to prevent kidney injury, like basic nutritional support, glycemic control, and minimizing the nephrotic drugs. Goldstein et al. In Cincinnati Children's Hospital, where he has done nearly 1,700 odd patients, pediatric patients, where he implemented surveillance. And this in surveillance system, he reduced the exposure rate nearly by 38% and acute kidney injury rate by nearly 64%. So if you have awareness of the acute kidney injury and you identify them prior, then there is a significant chance of reducing the acute kidney injury post-op period. What are the goals in the intraoperative period? Basically, most important is the maintaining a fluid balance and avoiding the hypertension. A vasodilatation always treat with the fluid first. If it is not responding to fluid, then go ahead with using the vasopressors. Target mean pressure more than 65 millimeters of mercury. Risk of postoperative AKI being higher when the MAP is less than 60% more than 20 minutes, or MAP is less than 55 millimeters of mercury more than 10 minutes. These are documented evidences with these factors. Most of the time, basically what is required is the individualize the patient. individualize the patient for the intraoperative goal therapy to avoid the postoperative risk. And remember, avoid the fluid overload. So next, the pharmaceutical method for the management of the AKI. In pharmacology method, we have divided into two groups where the drugs is used and fluid. If you use as a drug, they can divide into two big categories. In case of drug, I'm concentrating more dopamine, N-acetylcysteine, dexmedetomidine, and statins. Dopamine, phenoldopan, and atyl nitric peptide studied in previous last 2 decades. They thought they increased GFR, hence diuresis, helping the avoiding the kidney injury. But large control trials and Cochrane reviews showed that there is no benefit of dopamine, and there is no concept of renal dose of dopamine currently, and it's totally outdated topic now. The same way, phenoldopan and atyl nitric peptide, they didn't show any great help. N-acetylcysteine is a precursor of the intracellular glutathione that reduces the oxidative dust in neutrophil, improving the oxygen and improving the free radical scavenging. But even this one also showed hardly any improvement in the contrast-induced acute renal injury. There have been a trial with allopurinol, selenium, zinc, vitamin C, vitamin B1, but none have showed any benefits. Even statins have been tried because of their oxidative help, but even they have showed any clinical benefits till date. Dexmedetomidine is a recent drug where been used significantly everywhere. It has increasing renal blood flow, capacity of renal blood flow, and decreasing the oxidative stress. So this has anti-inflammatory and anti-apoptotic features also. They thought it reduces the incidence of cardiac surgery, such as acute kidney injury in vascular and heart population. Is indicated, it's substantiated, but there is no mortality benefits as of now. Maybe we need still higher studies, higher recommended, high control data to recommend dexmedetomidine to use routinely. Acute kidney injury without mentioning the furosemide is incomplete. So what I have done is kept 3-4 question marks where how we can use in AKI. Whether it's contraindicated patient in RRT, renal replacement therapy, the answer is no. Because it might help in controlling the fluid balance. When there is still the patient is producing urine, if the patient has a volume overload, along with even the RRT, we can go ahead with using the Lasix. Should you stop if there is a progressive increase in the creatinine level? The answer is again no, because a situation where the venous congestion or renal compartment syndrome is there, where heart failure or hepatorenal syndromes, where the renal per se is not injured initially, but it's because of the renal congestion, the functional variation is there. To decongest, you can still go ahead with using the classics, the furosemide. Is it contraindicated in AKI? The still answer is no. Basically, in case of hypervolemia and hyperkalemia, it can be still used. And there is a debate infusion versus bolus, whether the furosemide helps in infusion versus bolus. And last trial has shown there is no benefit in either you can use infusion or bolus dose. The fluid replacement therapies in AKI, what we usually conventionally use the large volume of fluids when you do abdominal surgery, just to accounting the fluid deficit due to vasodilatation, hemorrhage, or a fluid accumulation in extravascular spaces. The introduction of the enhanced recovery after surgery protocols, the more restrictive pattern fluid administration is now proposed. There is a conflicting data. In the RELIEF study in 2018, the restricted fluid intake had no higher rates of any disability survival or compared to the liberal fluid intake. However, in abdominal surgery, the restricted fluid regime was correlated with the higher incidence of acute kidney injury, even though it didn't show any benefit in the post-operative period. So they came up with a conclusion that modestly liberal administration of the balanced salt solution does not create any substantial fluid retention. It appears to be safe to administer a fluid volume that slightly exceeds the zero fluid balance. Then came up the goal-directed hemodynamic therapy. Basically, the goal-directed hemodynamic therapy is to optimize the fluid resuscitation and the cardiac output to improve the microvascular circulation. There is Optima study. It came in 2014, in which they documented that the relative risk has come down by 0.84% and absolute reduction is around 6.8%. But there is still no benefit to like 7-day mortality and like hospital stay, those things. Whether there is like type of fluid what we use might influence the like AKI. Popularly, what we use is the normal saline, 0.9% sodium chloride. It's the first choice most of the times, but it has its own limitations. It can cause the risk of acid-base hemostasis, renal vasoconstriction, and a reduced glomerular filtration rate, and increased risk of acute kidney injury and death also. There are large trials. There are 2 large trials, like was to mention here, SMART trial and SALT trial. In SALT trials, what they did was like they compared the like acetylene saline with like balanced crystallized solution and the saline solution in the both medical ICU and surgical ICU. And in SALT trial, what they compared is a saline against the lactated ringer or plasma solution. In SMART trial, what the finding were, they like balanced crystallized solution when they used, the kidney event occurred only 14.3% compared to the 15.4% when they use the normal saline. And this is actually statistically significant. Among critically ill, using the balanced crystallites lowered death rate from any cause, and the new renal replacement therapy or chronic renal infection drastically reduced. Based on this, the balanced solutions are the primary choice for the volume resuscitation, but is also recommended now. SALT trial, where compared the like saline along lactate or regular lactate or like plasma light, they showed lower prevalence of the major adverse kidney events, and in same thing with the critically ill patient, non-critically ill patients also. The balanced crystallized treatment did not result in reduced time of hospital discharge, but it find there was like a lower prevalence of the composite death and the renal replacement therapy and a chronic renal dysfunction. It's worth to mention here like the hydroxyethyl starch, where the 2 studies like crystalline versus hydroxyethyl starch trial, CHESS trial, and the Scandinavian starch severe sepsis septic shock trial, SUCCESS trial. Both have documented the acute kidney injury, where they use a significant amount of the hydroxyethyl starch. To mitigate these, what they have come up with the solution is that every drug can be used safely and effectively when it is used appropriately according to its indication and in the right patient population. So basically, this creates like a lot of confusion when to use, but when not to use. Gelatin and albumin also they are tried, but nothing has like significantly come up with the solutions. So there are a few things like renal ischemic precondition is one thing where like to mention 1 or 2 lines. What they have tried is the renal ischemic precondition at a remote places, applying the pressure in the arm or so, raising the pressure around 200 millimeter mercury and keeping for 5 minutes. This remote level might help in the decrease in the renal incident in the post-operative to preconditioning the stress response. In cardiac surgery, there is like some like data to has like some benefits, but overall still it's not recommended. Now the last part my topic is the renal replacement therapy in acute kidney injury. The renal replacement therapy is a very simple one where when it comes to the clear indications. When we have a classic overload of the volume, which is refractory to diabetes, and serious solute imbalances and acidosis refractory to medical management, or overt uremic manifestation like encephalopathy and pericarditis, these are the clear-cut indication for the renal replacement therapy. But when it comes to the non-clearly indication, like which poses a lot of difficulties when there is a borderline, whether volume overload is there or not, acidosis is still borderline, can be treated with medication. So these indication, I think we have to individualize the approach, discuss with the primary consultant and critical care and nephrologist, then I take a call whether to go ahead with the renal replacement therapy. Available mode for the renal replacement therapy are the CRRT, which is continuous renal replacement therapy, intermittent hemodialysis, or popularly known as HD, and SLED, which is basically like sustained low efficiency dialysis in basically considered in hemodynamically unstable patient, and the peritoneal dialysis. The ideal mode and the correct timing is still a matter of debate. There is like in critical care scenario, the CRIT and SLED been compared, but there is no benefit as of now. I think in chronic renal failure, Dr. Maitri might discuss the like early versus late RRT, but I would like to mention the few lines here. Early versus late is initial chemotherapy is critical patient in ELAN trial. What they have showed is like benefit. This is the only study where they've like shown a benefit, but the most other studies showed like hardly any benefits. In ideal ICU trial, what they shown is there is no benefit from the like early initiation of the CRRT or like a renal therapy, because it showed to demonstrate the lowering mortality in 90 days, and 75% of the patients in the delayed group recovered their kidney function spontaneously rather than like landing up in RRT. So weaning from the renal therapy depends on the like 2 or 3 factors, which is like spontaneous increase in the diuresis more than 400 ml in 24 hours, not on diuretics, and on diuretics more than 1 liter in 24 hours is the indication of the renal recovery. Thank you.
Thank you, sir. Thank you for such a articulated presentation. So we shall be taking the questions at the end of the session. There are a few questions in the chat box, but they shall be attended to towards the end of the session. So shall we move on to the next talk, sir?
Surely, please.
Hello. So next topic is about chronic renal failure. So Dr. Rajesh is going to enlighten about chronic renal failure and anesthetic implications. Sir is an academic coordinator at BMH College in Calicut. He is a recipient of COPES Award, and he is a member of the editorial board in the India Journal of Anesthesia and the associate editor in IJS South Supplement Kerala. And he has up to 35 publications to his credit. So over to you, Rajesh, sir.
Thank you, ma'am. And at this time, I would like to thank the entire organizing team, especially Professor Bala Bhaskar, sir, for the kind invitation. I will share my slides. So can you see my slides?
Yes, sir, they're visible.
Am I audible?
Yes, sir, you're audible, sir.
Thank you. So I have no conflict of interest and no financial support. So my lecture objective is to stress upon pathophysiology of CRF, preoperative assessment, and anesthetic management. So now my basic aim is to enlighten certain points so that the postgraduates can develop on that points so that they can get better prepared for their theory as well as for the practical examinations. This is an opening remark by Dr. Holmer Smith. Is a renal physiologist. The composition of blood is determined not by what the mouth ingests, but by what the kidney keeps. So it's an important statement. And for anesthesiologist who deals with day-to-day in patients with the chronic renal dysfunction coming for non-renal surgeries or for any renal procedures, it's very important. That means by the time a CRF develops, the composition of blood is so altered with the fluid overload and electrolyte imbalance. And as anesthesiologists, we should not do further harm, so that we have to keep the renal function intact. So coming to pathophysiology, the diabetic and hypertension is the main culprits which contributes to the chronic kidney diseases, even though we have glomerulopathies, tubulointestinal disease, renal vascular disease, and obstructive uropathy. So by the time the CRF developed, the GFR is reduced to 10% of the normal function, and that's around 20 ml per minute. And the end-stage renal disease means when the GFR falls to 5%, that is around 10 ml per minute. And there is a wide range of organ dysfunction due to primary disease. That's what I described earlier, like chronic hypertension or diabetes, or due to the effect of uremia. And the patients, uremic patients has got an inability to excrete products of the metabolism of proteins and amino acids. And it has been shown that certain metabolic products are associated with certain particular organ dysfunction. For example, guanidinosuccinic acid, and platelet dysfunction. But that doesn't mean that the degree of platelet dysfunction correlates with the amount of guanidinosuccinic acid in the blood. And postgraduates, please note these points. They should be able to keep these headings. In the pathophysiology section, the patients will have fluid and electrolyte derangements, hematologic abnormalities, cardiovascular and pulmonary abnormalities. Hello.
Please mute yourself. Somebody, Mr. Prem Sagar, can you please mute yourself?
Immune function abnormalities and gastrointestinal abnormalities and neurological abnormalities. I will come to each point. Coming to the electrolytes, it could be a sodium retention, depletion, or the normal sodium values, which is even complicated by the use of diuretics and the cardiac function and the polypharmacy the patient is taking, like antihypertensive drugs. And most patients exhibit mild sodium and water retention. And when the patient has got vomiting and continuous diarrhea or pyrexia, there will be evidence of hypovolemia. And potassium is another important element. When there is an extracellular acidosis, cause an exchange of intracellular potassium for extracellular hydrogen ions, which has been described by the previous speakers. And in acute acidosis, potassium raised to 0.5 millimoles per liter approximately for each 0.1 unit decrease in pH. So that's very important for us anesthesiologists, because we should not induce hypercarbia. That has to be avoided at any cost under general anesthesia by our ventilatory strategies. Magnesium is handled much like potassium, and when there is a reduced excretion, as in CRF, there can be hypermagnesemia, muscle weakness, and it can potentiate non-depolarizing muscle relaxants. That's an anesthetic implications for us. And usually the patients has got chronic metabolic acidosis, and because there is a retention of organic anions causing progressive increase in the anion gap and fall in plasma bicarbonate. The implications for anesthesiologists is that there is a little reserve to counter acute acidosis, which occurs with ketoacidosis or sepsis. Coming to other important elements, which are with the mechanism is coupled together, like calcium and phosphate. In CRF, the renal production of calcitrol, 1,25-dihydroxy D3, declines, causing decreased intestinal absorption and reduced plasma calcium. And phosphate excretion is impaired, resulting in hyperphosphatemia. So the phosphate forms calcium phosphate with the calcium ions, and which is deposited in the skin and blood vessels, which can further reduce the calcium level. And this hyperphosphatemia has got negative effect on 1-alpha hydroxylase, which is responsible for the calcitrol production, which again deteriorates the conditions. And both hyperphosphatemia and hypocalcemia is a potent stimulus for parathyroid hormone secretion, and which results in hyperplasia of the gland and consequent metabolic abnormalities. So the patients with the CRF usually comes with oral calcitrol and calcium carbonate, both as a calcium supplement and calcium carbonate as a phosphate binder. So this is a very simple figure which the postgraduates can reproduce in their examination sheet. When the nephron destruction happens, there is a decreased phosphate excretion, and simultaneously there is a decreased vitamin D3 production and decreased intestinal absorption, resulting in hypocalcemia. And this hypocalcemia along with hyperphosphatemia can result in hyperparathyroidism with hyperplasia of the gland and metastatic calcium deposits. So coming to another important abnormality, which is hematological hemopoietic system, that is anemia. The patients usually have normochromic anemia, and because there is a decreased renal erythropoietin production, and uremic toxins reduce the red blood cell half-life also. Along with that, there is a dietary deficiency of iron and folate. But The body compensates by increasing the cardiac output and increasing the production of 2,3 dpg and shift the oxygen dissociation curve to the right and increasing the oxygen delivery to the tissues. So the patients generally tolerate this anemia very well. And there is no need to rapid correction of hemoglobin above 10 gram percentage because it can even worsen the hypertension unless there is an indication like IHD when the hemoglobin percentage can be maintained in general between 7 and 8 gram percentage. When you test a prothrombin time and APTT, which the levels will remain normal, but bleeding time usually prolonged beyond 10 seconds, it's due to platelet activities deranged with the decreased adhesiveness and aggregation. The basic mechanism is because of there is inadequate vascular endothelial release of one Willebrand factor and factor 8 complex, and consequently there is another factor which is leading to this increased bleeding time is this excessive endothelial nitric oxide production. You can manage the situation if the patient comes for emergency situation by giving pooled cryoprecipitate or giving desmopressin IV 0.3 microgram per kilogram body weight, or you can give conjugated estrogen. The desmopressin has got tachyphylaxis and has got a short half-life of 6 to 8 hours, whereas conjugated estrogen has got a long half-life of 5 to 7 days. Cardiovascular system abnormality is very important. Either the patient can have a chronic hypertension, which can lead to CRF, or with the effect of CRF, the patient can have a sodium and water retention, which can again worsen the systemic hypertension, and patient will be on multiple antihypertensive agents when they come for anesthesia. And it is improved significantly with the dialysis. There is also decreased plasma triglyceride clearance, which leads to accelerated atherosclerosis, which can produce both coronary and peripheral vascular disease, ischemic heart disease and peripheral vascular disease. So also there is a high incidence of dilated cardiomyopathy, left ventricular hypertrophy, pulmonary hypertension, even congestive cardiac failure in patients with chronic renal failure. And sometimes you can have metastatic calcifications in the valves, mostly in the aortic valve and mitral valve, and even rarely, they can have a aortic stenosis also. And hemorrhagic uremic pericarditis is also not uncommon. Coming to pulmonary abnormalities, the patient has got repeated chest infections. There is basal atelectasis, and the anesthetic implications is that these patients have a risk of postoperative pulmonary complications because of basal atelectasis, fluid overload, impaired humoral and cellular immune function, and decreased surfactant production, all of which contributes to the postoperative pulmonary dysfunction. Sepsis is a leading cause of death in patients with the CRF. There is the inhibition of cell-mediated immunity and humoral defense mechanisms, and there is increased production of pro-inflammatory cytokines and uremic immune dysfunction also. So you have to notice the superficial infections are very common. If there is it is there, you have to document, especially on the fistula and catheter sites, and you have to anticipate delayed wound healing also. Gastrointestinal abnormalities, so your patient can have anorexia, nausea, and vomiting, resulting in malnutrition. Urea is a mucosal irritant, and the patient can have GI bleeding at any point in the gastrointestinal tract, and the gastric emptying is delayed, and residual volume is increased, and pH is lowered, and patient has got acid peptic disease, and autonomic gastric paresis is very common, especially in patients with long-standing diabetes. So I have to consider these patients as full stomach patients. And there is wide spectrum of CNS changes, starting from the mild personality disorder to encephalopathy, the peripheral neuropathy like glove and stocking sensory loss, to motor changes are there. And when these patients come with the peripheral neuropathy, motor weakness, you have to anticipate autonomic neuropathy and delayed calcium emptying and postal hypotension. And even there is evidence of silent myocardial infarction. That is the implications for the anesthesiologist. And usually the dialysis and renal transplantation may improve the neuropathy. So coming to preoperative assessment, I'm not going in detail. You have to have a thorough history and physical examinations and do the investigations. I will come to that. Note the dialysis access and possible venous access for you in the perioperative period, and note the timing of dialysis and the regular medications. Patients will be having a lot of medications. You have to note all these medications, whether they have to be continued or not. I'm sure Dr. Subsequent speaker will be dealing with all these things. I'm not going into detail. And check in the comorbidities the patient is having in the history, whether they are adequately controlled, whether the hypertension is controlled, whether the patient have a strict diabetic control. What is the HbA1c values? The diabetes tend to be brittle. That is very difficult to control. There will be periods of hypoglycemia and hyperglycemia. And also look the effect of uremia on the body, like anemia, coronary artery disease, hematological abnormalities, and the functional capacity of the patient. It also has to be noticed. Whether the patient has got radio contrast exposure in the previous day as an investigative modality for their surgical workup. And what is the dry weight of the patient? Usually the patients, there will be in the case sheet, or the patient will be able to tell you it's dry weight. That is very important to know the dry weight for us to have the perioperative fluid management. In addition to routine investigations, you have to note the baseline and current renal function values. eGFR is very important so that you can note a postoperative renal dysfunction or worsening of the condition, and the recent coagulation profile, especially after dialysis, and biochemistry and acid-base status post-dialysis, baseline and post-dialysis electrolytes, ECG and chest radiographs. I don't have to emphasize on the importance of this. And these patients carries very high risk and carries a high morbidity in the perioperative period. So you have to have a AHA perioperative cardiovascular evaluation for non-cardiac surgery. So it is very important to note the dialysis access, check the patency, auscultate whether you can see the bruit, and check for any signs of infection. If it is so, you have to notice it and inform your team, and protect the fistula site. That is very important. The students should be able to reproduce it either in the theory examination or in the practical examinations. Forward blood flow draws from the fistula site or in the arm, and BP measurement should not be on the arm. And if you are difficulty in getting a peripheral access, you can go for internal jugular venous access. Especially, it is very safe nowadays with the ultrasound technique. You have to, only thing in this, you have to follow strict aseptic conditions. And subclavian vein should be avoided due to risk of central stenosis. And central line should not be inserted on the same side as arteriovenous access. And dialysis patients should not have a peripherally inserted central cannula unless they have a short life expectancy, because you'll be destroying a potential AV fistula site for the patient in future. And the timing of dialysis and the frequency has to be noted. Ideally, the patient has to be dialyzed on the previous day. It's best to dialyze on the previous day. And the patients awaiting dialysis may be hypervolemic, and patients dialyzed recently, that is on the day of surgery, on the previous day, maybe sometimes hypovolemic. Ideal time is 4 to 6 hours, which is best for the fluid compartment equilibrium and clearance of the residual heparin. Suppose the dialysis, it's an emergency basis and the dialysis has to be done on the same day. You can either a nephrologist will be doing the heparin-free dialysis most of the time, which has to be clarified in consultation with the nephrologist. And as I said before, the patients will be on multiple antihypertensive agents like ACE inhibitors, ARB, which has to be stopped on this day of surgery because continuing these agents may sometimes produce severe hemodynamic disturbances in the intraoperative period. Diuretics, if the patient is dialyzed ideally, like in the previous day or on the day of surgery, continuing the dialysis can cause electrolyte and hemodynamic changes. So it has to be, whether it has to be continued or not, is you have to discuss with the team. And phosphate binders, sometimes the patient, most of the time, the phosphate binders patient will be on oral phosphate binders. It has to be discontinued in consultation with the nephrologist. And please note that oral hypoglycemic agent has a prolonged half-life in CRF patients. So what are the, coming to anesthetic management, what are the anesthetic goals? As I said in the opening remark, we don't want to have further deterioration on the renal function. And our goal is to maintain euvolemia, maintain the renal perfusion, and avoiding nephrotoxic medications. Postgraduates should be able to highlight all these points in the answer sheet. So coming to intraoperative monitoring, it depends on the duration of surgery and how severe you are anticipating the fluid shift in the intraoperative period. You have to have the standard monitoring, and because the patient is more prone to hypothermia, you need to have a core temperature monitoring, central venous access pressure monitoring for major procedures, neuromuscular monitoring to affect the patient, safely reverse the patient. You can have a neuromuscular monitoring also. Direct arterial pressure monitoring is not indicated unless you are anticipating a major fluid shift and it's a two cavity surgery or a major surgical procedure. But caution should be there not to disturb the future fistula sites. So I'm not going to the pharmacology, but for the completion sake, I am highlighting the higher doses of propofol is required for clinical endpoints. And etomidate is well tolerated and which preserves the hemodynamic stability. Fentanyl is much safer than morphine and pethidine because fentanyl is metabolized in the liver and only 7% is excreted in the urine, and metabolic products doesn't have much action. Succinylcholine can be given if potassium level is less than 5.5 milliequivalent per liter, which should be there in a well-dialyzed patient. Sevoflurane, there was a theoretical concern, but the FDA says that you can use it for at less than 1 liter per minute for an exposure up to 1 hour, and at least more than 2 liter per minute for more than 1 hour surgical procedures. The muscle laxant of choice, because atracurium and cisatracurium, it has got a definite value in patients with the CRF because of the type of metabolism they are having. I'm sure the next speaker will be highlighting on these points. And renal elimination half-life of anticoagulants is prolonged, which is somewhat protective because the recurrization, it will be protecting the recurrization process also. So there are indications for emergency dialysis when the patients come for surgery procedures, like in uncontrolled hyperkalemia, even with the medications, there is fluid overload, and this patient has got severe pulmonary edema of fluid overload, severe metabolic acidosis, uremic toxicity, or in patient is in coma. These are only definite indications. And coming to regional anesthesia, yes, you can give regional anesthesia. It can be much safer also in sometimes, but you have to consider the slow onset because of low serum bicarb levels and shortened duration because of reduced protein binding, and risk of coagulopathic complications should be considered. I have described earlier during the coagulation, when we are discussing the coagulation profile. And regional anesthesia has got definite benefits in CRF patients because it reduces the opioid requirements, pulmonary complications, and thromboembolic episodes. So to conclude, there is a unique pathophysiological changes relating to both chronic kidney disease and due to underlying disease which precipitated chronic kidney disease. So We have to be aware of this process, for the pathophysiological process, to have the patient anesthetized in a better way. And patient usually have a metabolic acidosis, hyponatremia, hypothermia, and hyperkalemia. All this has to be kept in mind. And there is high incidence of ischemic heart disease, which is often silent even in non-diabetic patients. And patient dysfunction can contribute to bleeding complication, which has to be kept in mind. And is best dialysed on the previous day of the surgery. And we anticipated it is best to have either euvolemic or near normal electrolyte panel while we take up for the surgery, but we may not have an ideal setup in most of the situations. Regional anesthesia, yes, we can give safely if the choice is appropriate for the surgical procedure. And the pharmacokinetics, metabolism of anesthetic agents, and the influence of anesthesia on the renal system has to be kept in mind before safely anesthetizing these patients. Thank you for the patient listening.
Thank you, sir. Thank you, sir. That was an excellent presentation and well summarized. Anybody has doubt, can you please type it in the chat box? And I can see many doubts regarding the pharmacological drugs and all. So that shall be taken up by the next speaker, that is about pharmacological considerations in renal failure. The next speaker is Dr. Maitri Shankar. She is a nephrologist and she's an assistant professor in the Institute of Nephrology and associate program director of Nephrology Social Media Collective. She also has a GLOMCON fellowship instructor and she's a secretary of the WIN India Karnataka chapter. She's a recipient of the gold medal, Dr. H.L. Trivedi Gold Medal in DNB Nephrology. She is also the recipient of the Best Paper Presentation and Best Thesis Award. She has more than 60 national and international publications, and she's a principal investigator in the RGHS research project. Over to you, madam.
I'm unable to share the screen. I think Dr. Rajesh sir has to stop sharing the screen.
Okay.
Yeah, done.
Thank you so much, Dr.
Sorry.
Thank you so much, Dr. Bala Bhaskar sir and Dr. Jyotsna for providing me this opportunity. I'm going to play my recording.
Dr. Maitri, the audio is no. Dr. Maitri, there's some issue with the audio.
Are you not able to hear?
No, we are not able to hear. The volume is quite pretty low.
Can you try increasing the volume in your systems and see? If it is not, then I will present it.
Oh,
Dr. Maitri, I think it's not very clear.
Okay, I think I'll only present them.
Yeah, if you can do that, it would be very nice.
Yeah. Can you hear me now?
Yeah, it is clear. We can hear you.
Yeah. So this is the brief agenda of my talk: introduction and the challenges that we face while prescribing pills in patients with chronic kidney disease. and the basic principles of pharmacokinetics, impact of chronic kidney disease on pharmacokinetics, how do we go about quantifying GFR, and how do we prescribe drugs to patients with chronic kidney disease. So we are all well aware that the prevalence of chronic kidney disease has been increasing, and end-stage patients on dialysis have several comorbidities that require pharmacological management. Like, they will be having diabetes, hypertension, coronary artery disease, anemia. And to control all these comorbidities, these patients are on multiple drugs, and they take on an average 12 different medications with a median daily pill burden of 19. So because of this polypharmacy, they are at a heightened risk of medication-related problems. And it has been reported that there is one medication-related problem for every 2.7 medication exposures in dialysis patients. Also, the dosing errors are rampant in patients with chronic kidney disease. So the challenge is that there is limited pharmacokinetic data available for patients with kidney disease. And even for newer drugs, there's not much pharmacokinetic data that is published. In fact, FDA does not even ask for the pharmacokinetic data on dialysis patients or patients with kidney disease even before approving the drug. So this requires some basic methods, some basic knowledge about the pharmacokinetic principles of the drug and some methods to assess the kidney function. So what is pharmacokinetics? It is effect of the body on the drug, and it reflects the physiological process, that is absorption, distribution, metabolism, and excretion. Each of these processes can be altered in kidney disease. So the concentration time profile of the drug reflects the net effects of these pharmacokinetics following drug administration. When I say concentration time profile of the drug, this is what I mean. This is the concentration time graph that we all should be aware of. Here, this is the absorption phase. And Cmax is the highest concentration seen. And this occurs at a time that is called as Tmax. And then it decreases over time. And the rate of elimination is defined by the elimination half-life, which is the time it takes for the drug concentration to decrease by half. These are some important principles because I will be referring to them time and again during this presentation. So when we take a drug orally, it undergoes intestinal absorption, then it goes into the liver, gets metabolized in the liver, and gets excreted in the bile via feces, or it can undergo intrahepatic circulation. Otherwise, the other parts of the metabolites can enter the bloodstream and affect the tissues, because by affecting the tissues, it can either cause effect of the drug or the side effect of the drug. Finally, it undergoes kidney clearance and excretion via the kidney. Approximately 70 to 80% of the drugs are excreted by the kidney. So what is bioavailability? Bioavailability is a fraction of the drug which reaches the systemic circulation unchanged. So when we give a drug in IV route, it has a bioavailability of 100% and it is symbolized as F. The amount of drug that actually reaches the target organ is called as a therapeutic effect of that particular drug. So when we take a drug orally, it gets destroyed in the gut, it is not absorbed, destroyed by the gut wall, destroyed by the liver, and finally some amount of drug reaches the systemic circulation. So this is the bioavailability of the drug. So you can see here the area under the curve for injected is 100% and area under the curve for oral drug is the smaller one. You can see that the concentration maximum is lesser.
Dr. Maitri, you're there?
No, I think madam's video is stuck. I think somebody needs to call.
Or technical issues, Jyotsna?
Sir, I'm on a call with her, sir. I have informed her, sir.
Yeah.
Okay.
Dr. Jyotsna, you were able to contact her?
Yes, sir, I could contact her.
Okay.
She's looking into
I'm
it,
checking.
sir.
I'm checking. The
Yes.
Wi-Fi. There's some problem with the Wi-Fi. I'm connecting.
Yeah. But there seems to be an issue with internet connectivity, sir. She's trending into it.
I have admitted her now.
Yeah.
Yeah. Can you see now?
Yeah, it's visible and audible as well.
Yeah.
Sorry for that. So the drugs which have a smaller volume of distribution are small in size, lipophilic, and bound to the tissues. And drugs with larger size, charged, and who are which is bound to the plasma protein is just within the intravascular compartment and within the plasma. So how do we calculate volume of distribution? Supposing we inject 100 micrograms of drug, and then we check for the level of the drug in the plasma, it is 4 micrograms per liter. Volume of distribution is calculated as 100 divided by 4, that is 25 liters. And the volume of plasma in an average adult is 4 liters, interstitial fluid is 10 liters, intracellular is 28 liters. So any drug with a with such huge volume of distribution of 25 liters is definitely just not confined within the plasma, and it has gone into the tissues as well. So how do we, what is clearance of the drug? Clearance of the drug from the systemic circulation is calculated as hepatic clearance plus renal clearance and other clearance. Hepatic clearance we have just discussed. About renal clearance, kidneys filter unchanged drugs or metabolites into the bladder. Increase in blood flow increases the clearance. And in renal failure, what happens is there is decreased ability to filter the drug, and because of which there is decreased clearance. So renal excretion is equal to filtration minus reabsorption plus secretion of the drug. Elimination half-life is the time required to eliminate half of the drug from the body. So we need to know the first order kinetics and zero order kinetics. This on the y-axis, we can see rate of drug metabolism, and on the x-axis, it is plasma drug concentration. So in first order kinetics, a constant proportion or fraction of the drug is eliminated per unit time. There is no saturation of metabolic enzymes or carriers that are needed. And this first order kinetic drugs will have less liable to accumulation and toxicity. So these are the kind of drugs which we will prefer in patients with chronic kidney disease. If you look at zero order kinetics, your constant amount of drug is eliminated per unit time, and all the metabolizing enzymes and carriers are saturated. And the drug or the metabolites gets accumulated and causes toxicity. So it is better to prevent drugs with zero order kinetics, and the drugs which follow first order kinetics are useful. So T half is calculated as 0.693 into volume of distribution divided by clearance. And you can see that in patients with kidney renal failure, the clearance is obviously reduced. So the T half gets automatically increased since it is inversely proportional. So what is the steady state concentration? It is a situation at which the rate of drug administration is equal to the rate of drug elimination. So the amount of drug remains constant within the therapeutic range. Steady state concentration is usually reached after 4 to 5 half-life times of the drug. So after 4 or 5 half-lives, we will reach the therapeutic range, which is between the MEC and MTC. MTC is the minimum toxic concentration. Beyond this, the drug becomes toxic, and MEC is the minimum effective concentration. Below this, the drug becomes ineffective. So what we have to achieve is therapeutic range, and this is the steady state or the concentration steady state CSS. And this is calculated as dose into bioavailability, dose into bioavailability divided by the dosing interval into clearance. So steady state is calculated with the help of clearance. So loading dose compensates for volume of distribution and maintenance dose compensates for clearance. So we calculate loading dose as volume of distribution into the steady state divided by bioavailability. And maintenance dose is calculated as dosing rate, that is clearance into steady state divided by bioavailability into the dosing interval. So clearance is very important for maintenance dose, and for loading dose, it is the volume of distribution. So this is the therapeutic index of the drug, that is between minimum toxic concentration and minimum effective concentration. Drugs with narrow therapeutic index like digoxin, lithium, phenytoin, theophylline, and warfarin are better if they are avoided in patients with kidney disease. Therapeutic index is calculated as minimum toxic dose divided by the minimum effective dose, and drugs with wider therapeutic range are always safer in patients with chronic kidney disease. These are three patterns whereby drug clearance varies by GFR. So this graph shows as GFR decreases from normal to down, there are changes in drug clearance. So if you start with drug P, for example, the red line, we can see that they are directly proportional. When you've got no kidney function, you've got no drug clearance. So this drug is cleared entirely by the kidneys and does not have any extra renal clearance at all. So examples of drug B would be beta-lactam antibiotics and anticoagulants like dabigatran. If you look at drug C, no matter what the GFR is, the clearance is does not get affected at all. So this drug is entirely cleared by extra renal routes, mainly the liver. The example for drug C would be macrolides and warfarin. Drug A has a mixture of both renal clearance as well as non-renal clearance. An example for drug A would be quinolone and rivaroxaban. Coming to principles of dose adjustment. So to prescribe a dose, we have to consider therapeutic range. What is the loading dose that is required? The maintenance dose and frequency. When dose adjustment should be considered, and the possibility to conduct any therapeutic drug monitoring, that would be very helpful. Also, the prescriber should try to obtain any published pharmacokinetic data from comparable patient population, which is mostly lacking. Interpatient pharmacokinetic variability also adds some degree of uncertainty to some of our predictions. And when I say interpatient pharmacokinetic variability, it mainly means the pharmacogenetics of the patients. Maintenance dose largely depends on the clearance, as I already mentioned, and drug clearance varies widely in patients with impaired kidney function depending on what their kidney function is. The decrease in drug clearance with impaired kidney function prompts either a decrease in the maintenance dose, maybe we give lesser milligrams, or we increase the dosing interval. So which option to choose? This depends upon the toxicity profile of the drug, whereby giving higher doses less frequently may predispose to some toxicity. On the other hand, less frequent dosing improves compliance in our patients. So when we have change in pharmacokinetic, patients can have different time concentration profile. If you look at the black line, that shows what is happening with normal pharmacokinetics. If there is halving of clearance in a drug that is taken orally, we can see what happens with the red line. There is slightly higher concentration and it persists longer. If we contrast that to patients with doubling of their volume of distribution, we get what we see in the blue line, where the Cmax won't be high because there is a relative dilution and it has got more volume to distribute across, and the T half of the elimination is also longer. So let's see the impact on therapeutics. So red line shows the halving of clearance, and we can see that there is accumulation and it is accumulating very rapidly if you look at the red line. This happens if we don't change the dosing regimen in the context of reduced kidney function. Especially important is in patients with renal disease. So in contrast, if you double the volume of distribution, we get a lower concentration, as you can see in the blue line. But again, we get accumulation to the point that it could cause toxicity. But this takes some longer period of time to occur. So both these conditions may be occurring in our patients with chronic kidney disease, and we have to be careful with dose adjustments. So you can see here that if you prescribe gentamicin in patients with chronic kidney disease without any dose adjustment, we get accumulation of the drug as seen in the red graph. So what we can do this is we can address this problem by two methods. We know that the efficacy of gentamicin depends on how high the concentration is. So we cannot reduce the dose of the drug because it is directly dependent on the efficacy of the drug. So what we should do instead is increase the dosing frequency. Decrease the dosing frequency. So when we do this every second day, there is less accumulation, but still there is accumulation. And if we go on doing this every third daily dosing, we see even more lesser accumulation. So simply by prolonging the dose interval, we can decrease the toxicity of the drug. So what is the impact of chronic kidney disease on pharmacokinetics? First step is absorption. So absorption is variable. Common thought is that absorption reduces because of edema, but animal and human studies have shown that drug absorption may actually increase, especially in drugs with low bioavailability. Why does absorption increase in patients with chronic kidney disease? This is because of uremia and its toxins and the effect of edema. These are the enterocytes, and you can see that the enterocyte tight junctions are lost and they become very loose. And there is paracellular leak of the drugs that is happening. So this increases the absorption. Also, the gastric pH becomes more alkaline. There is decreased activity of the cytochrome enzyme, because of which the drug levels again increase. And there is reduced influx pumps and reduced activity of the efflux pump, like organic anion transporter and P-glycoprotein pumps, which are most important efflux pumps, which remove the drug or its metabolite from the enterocyte to the outside. So the activity of those pumps is reduced. Volume of distribution, it varies with body mass and composition, muscle and adipose tissue especially. It increases in advanced chronic kidneys because of hypoalbuminemia. There is a lot of fluid retention and decreased protein bounding. Presence of severe edema is inconsistent. Volume of distribution may either be same or double. And in sarcopenia, if you see, that is an advanced chronic kidney disease, volume of distribution gets decreased. So fluid overload affects the volume of distribution of particularly hydrophilic drugs more than lipophilic drugs. You can see here that albumin binds weakly acidic drugs, and in conditions of CKD where albumin levels are low, there is increase in the free drug level. And uremic toxins, they displace the drugs from the protein binding sites. So because of which, again, there is increase in the drug level. How do we quantify GFR? There are multiple equations to quantify GFR and multiple methods. Most common that is used is serum creatinine method. This was recently discussed by the previous speakers. Creatinine clearance, estimated creatinine clearance, eGFR by CKD EPI equation, and eGFR by MDRD equation. Measured GFR is usually done for research purpose, and it is the gold standard using iohexol. Earlier, inulin used to be used, but that is a very cumbersome procedure, and serum cystatin based equation. But most commonly what we use is serum creatinine based, and studies have shown that none of these methods is superior over the other. So usually what we do is we download the National Kidney Foundation applications from online or the website, and we download the CKD EPI creatinine based 2021 calculator. You just have to enter age, gender, and creatinine, and you will get eGFR calculated automatically by the calculator. No matter which calculated or measured method you use, creatinine-based method, none of them is closer or equal to the measured GFR. You can see the measured GFR here in the black line, whereas the estimated GFR is all over the place, usually -30 to +30 from the black line. This is the eGFR calculator that I was talking to you about. What is important is if you're using creatinine clearance equation, you have to know that if you're taking an obese patient, then it overestimates the GFR. So we have to use adjusted ideal body weight if it is the creatinine clearance method. And if you're using estimated GFR method, it will underestimate the GFR. So we have to use the de-indexed eGFR method. So here, Y-axis shows the non-renal clearance. Now we'll be looking at the non-renal clearance of the drugs in patients with kidney disease, and X-axis shows the GFR. So this graph shows a decrease in non-renal clearance in patients with reduced renal clearance for a whole range of drugs. So not just renal clearance, but non-renal clearance is also decreased in patients with chronic kidney disease. Each of these drugs are chosen because they are probes for different drugs. For example, theophylline is a probe for CYP450, rosiglitazone is a probe for 2-cytochrome 8, bosentan 2C9, omeprazole 2C19, and midazolam for 3A4. So we can also see here that not all cytochrome enzymes decrease to the same level. For example, omeprazole, which is a probe for C19, has decreased to 25% here with a drop in GFR, while rosiglitazone, the green one over here, has decreased only to 50%. So there's a lot of variability. Also, not all the drugs metabolized by cytochrome will change to the same extent. So we cannot predict which drug reduces by what extent. Why is this? Why we can't predict is because the circulating uremic toxins will inhibit the cytochrome enzymes and impact them on the drug clearance. So perhaps with higher level of uremic toxins, we have severe inhibition of these enzymes. So you can see here, they have looked at the erythromycin breath test. That is, prior to dialysis, what was the level of erythromycin, and post dialysis, what is the metabolism of erythromycin. So pre-HT, you can see that it is very less, the exhaled erythromycin excretion rate, whereas post-HT, it is much higher. So it is basically the uremic toxins which is preventing the extrarenal metabolism from happening. So you can see here also, as the GFR goes lower down, the uremic toxins are getting accumulated and the extrarenal metabolism is also reducing. This is another example. We have seen about enzymes. There are also transporters, drug transporters, which play an important role in drug metabolism, like organic anion transporter and P-glycoprotein transporters. These are the important transporters. For example, they have done this study with fexofenadine. It is not metabolized, but it is a substrate for transporters, P-glycoprotein and organic anion transporter. These transporters are active transporters, and their role is to reduce the absorption of the drugs. They are found on RBCs, and they extrude the drug before being absorbed. So you can see here that the Cmax, Tmax, area under the curve, and T-half has increased in end-stage kidney disease patients compared to control, while the drug clearance has decreased. So this means that there is an increase in absorption, probably because the efflux transporters are not working very well. So these efflux transporters are inhibited by these uremic toxins. To further prove this fact that uremic toxins inhibit these transporters and enzymes, Nolan and his associates, they incubated rat hepatocytes and rat enterocytes with human end-stage kidney disease plasma. And they looked at the levels of P-glycoprotein and organic anion transporters and cytochrome activity. And you can see that all these are reduced in patients with end-stage kidney disease. So what is the mechanism? It is the action of organic anion transporter, P-glycoprotein and cytochrome that determines the disposition of many of the drugs. So briefly, the oral administration of drug D, that is the green circle, it comes in contact with enterocytes lining the lumen of the gut wall, where it may either diffuse or undergo active organic anion transporter mediated uptake across the apical membrane into the enterocyte, followed by cytochrome metabolism. Subsequently, the metabolite is either actively counter-transported via P-glycoprotein back across the apical membrane into the gut lumen, or it will be fecally extruded. Sometimes it can also get translocated across the basolateral membrane into the portal circulation. So once in the portal circulation, drugs and metabolites will either diffuse or undergo organic transporter mediated uptake across the sinusoidal membrane of the hepatocyte, again followed by cytochrome metabolism. Then it is again excluded back into the by P-glycoprotein efflux or the MRP, that is multi-drug resistant protein 2 channels into the bile caniculus, and then it gets excreted. So all these P-glycoprotein efflux, organic anion transporter, and cytochrome levels are reduced in patients with kidney disease. You can see here that there is decreased hepatic expression of phase 1 and phase 2 drug metabolizing enzymes. And also these uremic solutes, they come in between the binding site of drug with the enzyme. This is again P-glycoprotein, which is reduced in chronic kidney disease patients. Also, the etiology of kidney disease plays an important role. For example, if you look at ampicillin and cephalexin, it is 25% lower in those with tubular dysfunction compared to those with glomerulonephritis for the same amount of GFR. So this is the nephron. The drug is filtered by the glomerulus. There is active drug secretion, which happens in the proximal tubule, and active drug absorption in the distal tubule. So we compare these three drugs, benzyl penicillin, it has 50 to 70% secretion in the proximal tubule. So if there is tubular dysfunction, this will impact the secretion. Same applies for metformin also. Even that is actively secreted by organic anion transporter, and much of the clearance is based on this secretion only. So we have very high total clearance for benzyl penicillin and metformin because of the active secretion in PCT, even though these drugs are actually cleared by the kidney. So tubular damage will impact clearance and does not relate to the intact nephron hypothesis. And fluconazole has active reabsorption. So we have to reduce the dose to an extent in fluconazole. Dose adjustments in patients with chronic kidney disease are also based on the change in concentration time profile for the drug of interest. Compared with patients with no kidney disease, those with advanced kidney disease receiving dihydrocodeine showed decrease in clearance and an increase in mean area under the curve concentration. So to achieve concentration similar to those in patients without kidney disease, we have to increase the dosing interval. You can see here that the area under the curve is increased by 70% and concentration maximum by 29%. So if the area under the curve is increased by more than 50%, then we have to prolong the duration, dosing duration. If the concentration maximum has increased by more than 50%, then we have to reduce the total dose quantity. Here you can see for oral repaglinide, the patients with advanced CKD mean area under the curve has increased by 232% and Cmax has also increased by 82%. So we have to decrease the dose over here and also increase the dosing frequency. Dialysis can also impact drug clearance. Smaller molecules have better dialytic clearance compared to larger molecules. Protein binding drugs that are extensively bound to plasma proteins have minimal dialytic clearance compared to drugs that are minimally protein bound. Small volume of distribution tend to have greater dialysability because they are restricted within the intravascular space. Also, type of the dialysis membrane, like high flux dialysis membrane, which has higher pore size, and the higher surface area of the dialysis membrane, they have higher drug clearance. And if we are keeping high blood flow rates and high dialysate flow rates, even they have higher dialytic clearance of the drugs. So why is this all important? These are unpredictable changes that happen in the pharmacokinetics in chronic kidney disease. We cannot predict exactly what exactly is happening. So it actually depends upon the severity of kidney disease and the dosing of the drug. And there is limited data. More drug trials are required in patients with kidney disease. And as I already mentioned, FDA approval does not require data on patients with kidney disease. All these factors are not considered by the clinicians and also by the guidelines that the societies make. So how do we prescribe to patients with chronic kidney disease? We have to aim to reach the therapeutic target. We should avoid subtherapeutic range. It will cause treatment failure, and supratherapeutic range will cause adverse effect. So common conservative approach is to start low and go slow. And depending on the rate of dose escalation, we have to look at the target, whether we have achieved the target blood pressure or the target HbA1c. So we can go slow here. We have to just keep monitoring the target. But there are some conditions where we have to go faster. Like, for example, anti-infectives or immunosuppressives. We cannot go slow over here. We need to act fast. So in such conditions, we have to look if there is any therapeutic drug monitoring which is available for those particular drugs. And therapeutic drug monitoring over here plays an important role. Summarizing, in dialysis and CKD patients, there is increased absorption because of the paracellular leakage, decreased efflux transporter activity, decreased P450 activity, and distribution. There is increase in free drug concentration mediated by decreased albumin. Uremic toxin mediated decrease in protein binding is also there. And metabolism, there is decrease in phase 1 and phase 2 metabolism. Excretion, both renal excretion as well as extrarenal excretion is affected. Both are reduced. Hemodialysis, it depends on the type of dialysis membrane, the blood flow rate, and the dialytic flow rate. So again, post dialysis, the drug concentration is bound to reduce if the drug is dialysable. So changes are documented for absorption, distribution, metabolism, and excretion. Changes vary between patients, drugs, and severity of chronic kidney disease, and more data is required to better define these changes. Careful dose adjustment is always required. So this relationship only applies to steady state, that is chronic scenario. It does not apply to acute kidney injury where the creatinine change is dynamic. For further reading, you can check out this article on CJASN. It is Introduction to Nepropharmacology for the Clinician. You will find a table in which the pharmacokinetic parameters are different in acute kidney injury, chronic kidney disease, and kidney replacement therapy. For pharmacokinetics, we don't have to remember the volume of distribution of bioavailability and what is the dosing. We can just look up to drug dosing in dialysis books. There are various sources that are available. And this is a small chart that I had prepared for you as a handout. What pre-medications can be used: aspiration prophylaxis, benzodiazepines, induction agents, muscle relaxants, reversal agents, and opioids and CKD. I will share this as a PDF format with you because we cannot remember all the pharmacokinetics of the drug, just the basic principles we need to know. Thank you so much.
Thank you, madam. That was quite informative, and the postgraduates will definitely benefit from that handout. So over to Bhaskar, sir.
Yeah, thanks, Josna. First of all, I should thank Dr. Maitri because she was lost in the presentation list and there was some technical hitch. So there was some compounded problem, but it was worth the trouble and the wait also. We had a very nice presentation from Dr. Maitri. So in fact, she was referring to the final 2 to 3 slides where she has prepared a ready reckoner in terms of the various drugs and what would be their fate in patients with CRF. So she can share it with me and I can also distribute in the different groups, the PDF. And of course, we started with Dr. CGS Prasad. That is the most important part of the presentation because the PGs tend to just talk about urea, creatinine, and a little bit about EGFR and the Crockett's thing and everything, but they don't know why and how. So that was clearly highlighted by Dr. Prasad. And of course, when we went to the next topic of acute renal injury by Dr. Sudarshan, he talked about the limitations of creatinine also. So this was the one thing which is very important in these discussions. We say creatinine is the best one, and we also know we should know what are the limitations of creatinine. Because at a ground level, we'll only say, yes, somebody has got a good muscle mass, a low muscle mass, and we should be correlating with the creatinine level for the age and the muscle mass. So there was further information from Dr. Sudarshan and with respect to the various acute injury causes and the management, including the diabetic aspects and sepsis and other things. And CRF, Dr. Rajesh, as always, was very succinct and at the same time informative in terms of his presentation. Compressing CRF into the 20 minutes is definitely difficult, and he made it possible. So that way, it was also very good from his point of view. So all in all, it was Dr. Rajesh's presentations from whole group. And I did see that some of the questions in the chat boxes have already been answered. So that's very important. And also the take home is, yes, we should go back to the basics and understand in terms of the basic renal function per se, what are the different types of renal functions and what level, what happens in terms of even the pharmacokinetics and pharmacodynamics and the perfusion related ones with respect to the kidneys, whether it is one which is purely renal in origin or circulation related. So including the cardiovascular system and everything. So these are very well presented by all our 4 colleagues today. I think I am happy that there was so much of participation. So we touched about 100 and we had 30-40 presenters, participants in the YouTube also. Dr. Jyotsna, that's from me. Thanks from my side, and you please can take it forward.
Yes, sir. Any more questions can be typed or can be messaged, which will be conveyed to the presenters later. So for now,
I think one question is there.
Yes, sir.
One
question is the choice of antibiotics in AK to prevent sepsis and the dosing.
I think that has been answered already in the chat box.
Only the protein aspect.
Protein usually we see in dialysis patients, we have to give 1 to 1.2 grams per day. We don't have to restrict protein intake. And even in CKD patients, they say 0.8 grams per day and all 0.8 grams per kg per day. It is 1.2 grams per kg per day, sorry. Actually, in CKD patients, they say we have to restrict protein intake, but that is not true in Indian scenario because most of the diet which we take is vegetarian and we consume non-veg like once in a week or something like that. And our diet is already low in protein. So in protein restriction is not advised for CKD patients from India. It is basically for Western countries where they eat beef like all 7 days in a week.
That's an important take home because even at ground level, we say protein restriction is repeatedly discussed in CRF per se. So we need not be so protective against the proteins part.
Bala Bhaskar, sir,
Yes,
can
sir.
I add something?
Please go ahead.
As I'm here.
Yeah, please.
I think Sudarshan Lakhe, sir, beautiful points he brought out. I think a couple of take-home points for postgraduates is he mentioned many trials like 6S trial, that is Scandinavian starch for severe sepsis and septic shock. I think there was a comparison between Heta starch and Ringer's lactate. So the take-home message is the Heta starch, that is HES, hydroxyl ethyl starch showed increased mortality and need for the renal replacement is increased. So HES or Heta starch should be totally banned in these patients. The other thing is the Christmas trial that sir was mentioning, and these are all secondary outcomes. So again, HES versus normal saline. So what they said is, though the volume and time taken when you resuscitate with HES takes little lesser time, but still the secondary outcome is not good in these patients. So the other thing is we have this trigger to give normal saline in patients who come to the operating theater. I think normal saline is not anymore normal, as we all understand. And the reason is the sodium is 154 and the chloride is 154. The strong and difference is 0, sir. So the crystalloid, the normal saline, if at all, if anyone wants to give, should not be given more than 1.5 liters and maximum of 2 liters. And the best is the balanced salt solutions that can be used. So I thought I'll put in this thing. Thank you, sir.
Yeah, thank you. Dr. Sudarshan, you want to respond?
I think Adam sir already mentioned everything, sir. There are actually 2 ongoing trials. I couldn't find them. Like the phonic trials and the thesis trials. They are. I didn't get those trials where they're comparing the again HES with the regular saline. They're comparing. I couldn't get those data. If I get, like, I'll definitely circulate.
We'll continue our exchanges also. And yeah, Dr. Saji has one more panel question to Dr. Maitri, I suppose. He's talking about paracetamol. Can you?
I think, yeah, it has good oral bioavailability, and 4 grams is the maximum dose that we can give either IV or oral per day.
Okay.
And NSAID is definitely a no-no in CKD patients because it causes fluid retention, hypertension, and GI bleeds are also more. CKD patients are already prone for stress ulcers. So because of all this, we try to avoid, but some of them try giving ibuprofen and naproxen. They say naproxen causes lesser fluid retention and heart failure, and ibuprofen causes lesser GI bleed. But comparatively, these 2 are little lesser, but then NSAIDs are still not advisable to be used in patients with kidney disease.
Thank you. Thank you very much. Yeah, Jyotsna, I think.
Yes, so
Just
there's
a-
one more question regarding the contrast. That's from, I think Madam has already answered that.
Yes, thank you.
Yeah.
It's already answered.
Yeah, everything is answered because
Yes.
yeah, nobody was idle. Yeah, the chat questions also nicely.
Yes, sir.
Everything is attended. We can just conclude the session.
Yes, sir. Thank you. I thank all the presenters for their valuable time, and it was our privilege to have you. And so that all our postgraduates and the trainees are kind of enlightened, and they had a concise and focused briefing. And thank you all once again. And I also thank Dr. Bala Bhaskar for trying to conceptualize this packed program. So thank you all again.
Thank you. Thank you, madam.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thanks,
Thank
sir.
you,
Good
sir.
night, all.
Thank you.
Thank you, sir and madam. It was nice to have an interaction in this forum.